Welcome to Advanced Renal Topics for Nurse Practitioners. I'm John Tsai from the Long Beach VA Medical Center and the University of California Irvine Medical School. Now that we have discussed hyponatremia in quite some depth and have discussed different treatment options, all there is left to do is talk about how we deal with overcorrection and different strategies to ensure we don't overcorrect someone's hyponatremia. Recall from previous videos that we should typically aim for a correction of about 6 to 8 milliequivalents per liter per day for hyponatremia. In fact, there are some nephrologists that would even advocate for a lower rate of correction of about 4 to 6 milliequivalents per day. But I think personally the limit of 8 is very reasonable, and there are a few studies that correction to this point would cause osmotic demyelination syndrome, or ODS. We can see how this works with the following illustration. When patients have chronic hyponatremia, the neuron and myelin sheath are typically surrounded and maintained with a sodium of 120. With rapid correction, the sodium surrounding the neuron causes an osmotic shift, resulting in water movement out of the neuron. The water shift then results in shrinking of the neuron with a resulting demyelination, as the myelin sheath is not as responsive to osmotic changes relative to the neuron. The demyelination that occurs can cause permanent damage if it persists, and typically occurs in about 1/3 of patients with osmotic demyelination syndrome. Another third have no damage, and the other third have symptoms such as altered mental status, but no permanent damage. While we do have a theory of how demyelination works, does it really cause problems in real life? Actually, yes. Studies were thankfully not done in humans, but in rats, researchers saw that an increase in serum sodium by 20 points resulted in essentially fatal brain lesions. In addition, studies that have looked at limiting correction of hyponatremia found that limiting increases to less than 12 in 24 hours and less than 18 in 48 hours had relatively favorable outcomes. There were still people who had brain damage at those higher concentration levels, so we generally maintain our lower limit of about 6 to 8 milliequivalents per liter of correction per 24 hours. Similar to our calculation for body water excess when we were thinking about correction of hyponatremia, we can think about overcorrection as the other way around. In this case, we have an overcorrected patient that is corrected from 110 to 130 within the course of 24 hours. In this case, we have exceeded our maximum limit of about 6 to 8 milliequivalents per day, and we'll need to correct our patient back again to around 120 to prevent osmotic demyelination syndrome from occurring. In this case, we can calculate how much free water we need to provide this patient to get the patient back to 120. Remember that the sodium molecules and volumes must be the same on both the left and the right side of the equation, and if we do the algebra as we have done before, we find that our patient needs to receive back 3.5 liters of free water in order to correct them from 130 back to 120. In fact, this same calculation can help manage hypernatremic patients where we typically have a total body water deficit, and we need to calculate how much free water we need to give the patient to correct them back to normal. So here we have illustrated the first method by which we can correct an overcorrection of hyponatremia, which is by giving some free water back to the patient, and maybe sometimes a lot of free water back to the patient, as in this case. Sometimes this is reasonable, but as you can see in this case, 3.5 liters is quite a lot, and may not be reasonable in the clinical setting. Usually you will want to ensure that the patient is monitored very closely in the hospital when we are correcting hyponatremia, in case we end up with a situation like this where we have grossly overshot our target, and now we have to give back free water or to correct them to a reasonable sodium level. Aside from giving the patient free water again to correct an overcorrection, we can also use DDAVP to essentially induce a state of SIADH. Remember that DDAVP is the same as ADH, or antidiuretic hormone, but it is also commonly used in the ICU as the drug vasopressin. How does this actually work? Well, recall from a previous video on hyponatremia treatments that SIADH results in free water absorption and then causes hyponatremia in the setting of a hypotonic solution being given. So if we're able to artificially create a state of SIADH, then we could potentially bring the patient's sodium back down by giving a hypotonic solution like D5W. So this is exactly what we do by giving somebody DDAVP. The overall result is patients who get DDAVP maintain their serum sodium levels, and if we do give a hypotonic solution, this results in dropping of their sodium levels. Go back and review the concepts from part 4 video if this doesn't quite make sense to you. In fact, we can actually use a combination of the two medications, free water in the form of D5W and DDAVP, to reverse an overcorrection of hyponatremia if it's gotten too out of hand, as our previous example showed. Now, let's take a look at ways we can actually use DDAVP in the management of hyponatremia. There are generally three different strategies of when to provide DDAVP. The first is the proactive strategy. When you suspect that the patient may correct too quickly, we can preemptively provide DDAVP, create a state of persistent SIADH, and use a DDAVP in combination with 3% saline to precisely correct the sodium to a desired amount. We call the provision of DDAVP to create an SIADH state as a DDAVP clamp, and we use the term clamp because it clamps down on the amount of electrolyte-free water you produce in your urine. The second reactive strategy is to monitor the serum sodium levels carefully, and when the rate of correction appears to be headed towards overcorrection, the DDAVP clamp is instituted, followed by close monitoring to ensure that the serum sodium levels don't increase any further. After several hours have passed, the DDAVP clamp can be released, and the sodium can continue to rise on its own with close monitoring. In the third instance, we have already overcorrected and want to start the method that we discussed on the previous slide, where we induce a state of SIADH again and provide free water to correct an overcorrection. With all these, you can see the risk of ODS, or osmotic demyelination syndrome, is highest in the rescue strategy, since the patient is already overcorrected. Hence, ideally, we would like to stick with either the proactive or the reactive strategy if we can, and these two strategies have been shown to have better outcomes compared to the rescue strategy. Regardless of the strategy you select, you will want to be closely monitoring your patient's serum sodium and work with your nephrology colleagues to ensure that the patient does not overcorrect. There are some special scenarios regarding correction of sodium that are worth mentioning. The first is hyponatremia due to pseudohyponatremia, or hyperosmolar hyponatremia, as we had discussed in the first video in this series. In these cases, remember that the underlying sodium concentration is still normal, and there is usually an interfering substance resulting in the hyponatremia. Hence, apparent overcorrection is not very relevant, in these cases, given that the correction of the underlying cause frequently results in apparent overcorrection of hyponatremia. The prime example of this is in DKA, where patients have typically hyponatremia from high glucose levels. Once the glucose levels are corrected, the serum sodium levels will be seen to rise. Remember, though, that the total sodium amount in the patient remains constant and is still in the normal range, but it is only necessary to correct the hyperglycemia for the sodium level to return back to normal. There are no long-term consequences of this apparent overcorrection of hyponatremia. Additionally, some patients on hemodialysis will have apparent rises in their sodium levels after dialysis. This is a function of fluid removal and osmotic shifts during dialysis. While I won't go in depth today on this topic, it's helpful to note that the osmolality of these patients remains the same from the beginning to the end of dialysis, and this is due to the exchange of osmoles, and in this case of dialysis, it's usually urea for sodium. When the urea or other uremic toxins are removed, the sodium is given to the patient, and the osmolality remains within the normal range, since we are almost exchanging osmoles for other osmoles. Another thing to remember is that tolvaptan can also correct hyponatremia relatively quickly, since it causes an aquaresis. This is especially true in patients who are not able to drink an adequate amount of free water orally to make up for the rapid losses. To prevent this large overcorrection, it is important to watch the urine output closely, since this is the first sign that the sodium levels may be increasing too quickly, and to release the patient from any fluid restriction so that the patient can take in oral free water and prevent an even greater overcorrection. The other thing to note about tolvaptan is that the DDAVP strategies we discussed a couple of slides back to control overcorrection of hyponatremia is unhelpful in the setting of tolvaptan. This is because tolvaptan and DDAVP act on the same V2 receptor in the distal tubules. So if tolvaptan has gotten there first, DDAVP will not be able to knock tolvaptan off the receptor in order for you to create a state of SIADH. In tolvaptan hyponatremia overcorrection, you will have to give free water back and also wait for the tolvaptan to wear off. As usual, let's go over questions to see if you have understood today's material. A 55-year-old male with a history of chronic hyponatremia is admitted to the hospital for persistent falls at home. His serum sodium is noted to be 107, which is typically 120. The patient is given tolvaptan with a rapid increase in serum sodium over 8 hours to 117. Urine output is approximately 500 cc's per hour. What is your next step in management? Is it to give DDAVP? Is it to start a D5W infusion? Is it to recheck serum sodium after 1 hour? Or is it to recheck urine electrolytes? If you haven't finalized your answer yet, please feel free to pause the video now. If you selected to start a D5W or free water infusion, you are correct. In this case, we have a patient who has overcorrected their original hyponatremia, likely due to tolvaptan that was provided. Remember that in this case, while we typically have D5W and DDAVP available for us to correct a patient's overcorrection, in this case, the tolvaptan and DDAVP happen to act on the same receptors, and so that you're mandated to use only D5W in this case to correct his hyponatremia. Since we already know that the patient is corrected by 10 points over 8 hours, this is far higher than the maximum of 8 per guidelines. It is not reasonable to continue observation, nor is it reasonable to continue checking labs. An intervention must be done, which in this case has to be D5W. Well, we have come to the end of our videos on hyponatremia. I hope you have learned some stuff along the way and feel more comfortable at managing patients with hyponatremia now. When in doubt, always feel free to call us with any questions or concerns. Also, if you liked the video or have any suggestions on improvement for future years, please email me at my email address down below.